So, this is about MRI and it's about fusion. And my feeling is if you're going to fuse something, you need two things that work, and neither of these things do. So two wrongs don't make a right. My presentation is going to focus on MRI. Does it detect cancers of potential significance? How good is it to interrogate the prostate, extracapsular extension, tumor volume, and fusion? So MRI misses a meaningfully proportion of potentially significant cancers. The UCLA group, others have done a lot of work. How reliable is a negative MRI? This is a study of 588 consecutive men with MRIs, and they had had these before prostatectomy. And what was seen here is that in predicting the number of tumors and predicting volumes and so forth, it did not do very well. And if we looked at specifically, they looked at Gleason 7s and 8s and above, it missed 25% of significant cancers. And if that's acceptable, that's okay, but I don't believe it is. MRI does add something, but of the clinically significant cancers, lesions, 17% were missed. It has a false positive rate of about 20%. Not everything is perfect, and we know that. If you look at negative predictive value of MRI, a lot of it depends on what you call significant, but the negative predictive value is reasonable, but it's not as strong as some other things, 80 to 92%. And the negative predictive value varied by up to 21% depending on what your definition of clinical significance is. What about predicting extracapsular extension? This is a pretty straightforward thing that one can evaluate, fairly straightforward. And this was something that was done out of Nijmegen, and I would say that Dr. Balance from Nijmegen is one of the top MRI guys in the world. And looking at 183 patients undergoing radical prostatectomy, 50% had extracapsular extension. Looking at a 3T magnet, the sensitivity was 58%, specificity 89%. Negative predictive value, as you can see here, is only 68%.
What year was that?
So this was in the Journal of Urology in 2013. So predicting extracapsular extension at surgery, there was Peter Pinto and the group from the NCI had 553 men and had MRIs prior to surgery. And again, they had some challenges predicting the accuracy, and it was poor, and I'll come back to that. MRI typically underestimates tumor volume. This is looking at, again, a 3T magnet, looking at lesion volume and how accurately it did that. And we can see that there is some variation of up to 0.4 cc's in volume that is predicted with MRI. And this is important when we're looking at targeted therapy, which so it underestimated volume using the three parameters of MRI about, if you average this, about 25% of the time. There was another study from Pinto's group at the NCI looking at 135 men undergoing 3T multiparametric MRI prior to prostatectomy. And if you look at the correlation coefficient in this group of patients, it was not a good correlation. So in conclusion, MRI is a valuable imaging tool for screening and for targeting in prostate cancer, I believe. MRI has significant limitations. It is a tool. We use a lot of tools. It misses many meaningfully significant cancers with potential clinical significance. And this is one of the reasons why when MRIs are done, that the recommendation by most is to continue with 12-core biopsies. And so it's sort of a self-fulfilling prophecy in a way. MRIs, there's no question, you can see some lesions, and you take enough shots at them, you're going to find something. But many times these biopsies are negative, and just because you have a PIRADS 5 does not mean you have a cancer or a significant cancer. It's terrible for predicting extracapsular extension. It underestimates tumor volume and most dramatically for high-grade and high-volume cancers. So I think it's a major step backward to consider MRI for using this for targeted focal therapy. Yet a lot of people are doing that because, again, it's your target is the most important thing out there. And so there was that was the subject of our AUA crossfire was MRI for targeted focal therapy. And I think that we have pretty good evidence that there are limitations, the hardware, inter-reader variability, target localization, and so forth. So if you can't see a target, you can't hit it, is sort of shooting in the dark, plus cost. I'm going to look at the NCCN guidelines. We heard about the PROMISE and PRECISION trial. And basically what this says is that early detection indication for a biopsy, first you should repeat the PSA, DRE should be performed, workup for benign disease is that elevated PSA, the most common cause is BPH, and then consider secondary markers. And I would support the fact that some of the molecular markers are a lot less expensive and easier than multiparametric MRI. And in fact, if you read the guidelines, it says that the panel does recommend or consider MRI with trust biopsy, and they say, however, the panel cautions that false negatives can occur and proceeding to trust biopsy should still be an option. I think it's mandated today that you need to do biopsies. And the other thing is we have given up looking at ultrasounds. I remember when first ultrasounds, we first started doing it, we were talking about hyperechoic areas, hypoechoic areas, extension, things like that. And now we sort of got away from that. We just used ultrasound to put needles in the prostate. Now, as we see MRIs, we go back and we say, hey, look there was a lesion there that was on ultrasound. But we have something better. And what that is something called micro-ultrasound. It's where we are right now. The current ultrasound machines are probably about 6 to 9 megahertz. These are 29 megahertz. So 3 times or 300% improvement in resolution. So you can see better. And as a matter of fact, what this machine does, is actually put a MRI almost right onto that machine. And if you look at some of the micro-ultrasounds, what you can see here is what distinguishes this from the older ultrasound machines using now 29 megahertz. You can see details that you couldn't see before. And you can see cancers that exist here. You can see shading, you can see calcifications, you can see extracapsular extension, you can see a lot that you didn't see before. And so when you compare side by side micro-ultrasound with MRI fusion, what you see is with micro-ultrasound you get real-time visualization, real-time targeting. So you have the patient there, you can biopsy as you see. Ultrasound is much higher resolution, as I said, 300%. And it's just a few more minutes, and you can also, they have a grading system called Primus, which is very similar to PIRADS. If you look at MRI fusion, there's a significant learning curve for urologists and for radiologists. 40 minutes for an MRI scan, you got to read it, you got to score it, you got to give it a PIRADS, you got to fuse it, you got to bring it back with ultrasound, you got to perform a targeted biopsy, you got to reconfigure in any patient movement. There's complex workflow, multiple patient visits, costly without additional reimbursement codes, and high variability of results in the site, radiologist, MRI, and things like that. The other thing that's happening is and I witnessed this in a discussion with a family practice group in Orange County, a few weeks ago, is that the patients are going from the family practice doctor to the radiologist for the MRI, and they're doing the biopsies. And guess what? The urologists are left out of this treatment regimen, or diagnostic regimen. We need to maintain this. We've witnessed the same thing when ultrasound first came around. Those of you who've been around remember that. The challenge about this should be done by radiologists, not urologists. Unfortunately, we took that over. So I think we've got a new kid on the block here. We've got a new device that is comparable in price to the current ultrasound machines that expand our abilities and control these patients. We have actually compared 3D mapping biopsies to the micro-ultrasound, and this is something we're going to be presenting at the AUA this year. And we've also looked. Here's a radiation failure we were doing salvage cryotherapy on. Look at that. This guy's got extension right down to the rectal wall. You can see how nicely this appears. We did freeze this, but it's obviously impossible without having a hole in the rectum to do this, but it gives you an idea of what you can see. We've also used it for cryotherapy and monitoring it. So multiparametric MRI is something that is a tool that is useful, but I think we have better ways of dealing with it, and it should not be the gold standard. Thank you.